Warren Wong is our next speaker. Now, I know at the back you can't see it, so forgive me if I read it out for the people at the front. Principal Consultant, Care Management Institute at Keiser Permanante. And of course, for many of us in the UK, Kaiser Permanente, or KP, is held up as a model of ideal care. And of course, you were the Merck Fellow at the IHI. So we're really interested to have a very different perspective. Now, I also know that you're interested in multimorbidity and patients with complex needs, which is a topic that's of particular interest to us at the BMJ. So we'll hand you over to Warren.
Great. So Adrian, thank you so much. I was taking extensive notes while you were talking. And I think that many of you do know a fair amount about Kaiser. The context of care, of course, being in the United States is quite different. But I'll just try and see if I can add a little bit about what you know about Kaiser. We do take care of about 1 million older adults within the Kaiser system in the United States. One thing you might not know is that we have a Kaiser in Hawaii, which has a total membership of about 230,000. And something I know you don't know, and possibly don't even care about, is that twice a month I go to Maui, and even though that may sound like a lot of fun, I get up at 6 in the morning and don't get home till 7 at night. But I hope you are interested in what I'm going to talk about today, which is a little bit about the strategy related to older adult care within the Kaiser system, some of our current work and discoveries, and just a couple things that we feel we need to understand better. So 20 years ago, if I had started talking about let's have a meeting to describe model of care for older adults, there might be 5 people in the room, and the 5 other people in the room might be able to describe it just as well as I did. That is, of course, dramatically different now. Around the world, the issues of older adult care are quite dramatic. I was in Bath this last weekend and went to the RUH, and like Maureen said, started beyond seeing things to really understand things a little bit about the challenges in the UK. But older adult care is a burning platform within Kaiser Permanente, and our ability to survive and thrive really depend on our abilities to better care for older adults. And here are some of the challenges. First of all, the triple aim remains quite a bit an aspirational goal for us. We really have not a really clear idea about how we're going to accomplish the triple aim within the Kaiser Permanente for this population. We feel we're fairly certain that our membership of older adults will grow by about 20% in the next 5 years for a variety of reasons, including the very leading edge of baby boomers. But at the same time that our older adult membership is going to increase by 20%, our actual cost of care per member really needs to decrease by about 20%. And of course, there are multiple issues related to financing of Medicare in the United States. So these are all things we need to accomplish, and we are far from accomplishing them right now. So I'm going to talk a little bit about strategy at first, and we have a 3-part strategy. The first of it is that we actually, within the Kaiser system, do some things very well. And the problem is, of course, is that we do them very well in only a couple places. We don't do them very well everywhere. So our first part of our strategy is to do what we know we're doing well, the specific bundle of services that we provide that seem to work. We need to spread and scale up and spread them. So we do well in things such as transitions in care, palliative care, the continuum of care, providing care for our more frail elderly in community settings. And we have good models of all of those things. What has evolved within the Kaiser system is that the things that seem to work in one area frequently did not get adopted in other regions. But now with the pressures of financial performance and the reality of the urgency, our work is actually being spread much more rapidly. And one of the things that really assess with that is the fact that we have metrics across regions to show what the various regions are. And of course that kind of competition really helps move things along. So in terms of spreading and scaling up of our best practices, we're actually doing fairly well on that. Part two of our strategy is decreasing the unwarranted variation. And we are actually not doing as well in that arena. There is a marked degree of variation in hospital days per 1,000 of our older adult members, significant variation in the amount of the use of the intensive care unit, and significant amount of variation in use of diagnostics. And I'm sure many of you are familiar with the Dartmouth Atlas, which really demonstrates that the variation actually is not really directly correlated with quality of care. In fact, sometimes higher utilization is actually associated with lower quality of care and clearly higher costs. And it's interesting, we actually had one small study within the Kaiser system in which we found that there were a certain relatively smaller number of providers who ordered larger numbers of MRIs and CT scans. And when we looked at the panels of these physicians, their quality metrics were actually not very high. And interestingly enough, even the member satisfaction metrics were not very high either. So that is where we need to do quite a bit more work. So those first two things, trying to do our best work everywhere and decreasing variation, we think altogether that if we do that perfectly, we are likely to save costs by only 5%. And remember, what I was talking about was decreasing costs by 20%. So this is obviously not enough. So if we do what we do well, that is not going to get us where we need to go. So what we actually have to do is we have to change what we're doing. Does that sound a little bit schizophrenic to you? How much, just by a show of hands, how much does this occur in your lives where you're asked to do what you're doing better and at the same time asked to change what you do? Show of hands. I mean, yeah, so Kaiser Permanente may be, to a certain extent, a reincarnation of what is occurring in the NHS as well. The problem is it's very logical to do one or the other, but at this point we do not have the luxury of doing one or the other. We have to do both and do the best at what we're doing and at the same time change what we're doing. And of course that creates a lot of tension. I think all we can do about that is recognize the reason that tension exists. Because it doesn't make the tension go away, but to recognize the reasons and the urgency of the overall situation is really important. And so the change that we're talking about evolves around the whole concept of who does what, where it's done, and when it's done. So, for instance, where our care occurs is not just going to be in the hospital, in the ER, in the clinic. Care has to be everywhere. And when care is provided, is no longer at the convenience of the healthcare system. It needs to occur all the time. Now, the big question around this is, how are we going to do this? And, of course, we really don't have the answers around that yet. So, in this past year, I've had a certain luxury. I've had the luxury of working within Kaiser and saying, what's going on elsewhere? What are the best practices that we're seeing outside? And what can we learn about that within Kaiser to move the Kaiser system forward in our goals, our need, in our strategy. And the one in the middle, I've already talked about. Best practices exist everywhere. Going forward, we see that the work that we haven't really done much of within Kaiser, but we see as being really important, is community-based integrated care. And both Kaiser and IHR are very interested in this. In the UK, you actually have done much more work in this arena. Another primary driver is the whole concept of what is possible with technology, integrating technology with new models of care, and how to really create the impactful changes, pulling the two of those together. What we do see is the potential that technology may take off beyond our healthcare systems, that organizations that are primarily technology-based organizations and businesses may actually leapfrog healthcare systems and actually start taking healthcare on themselves. But what I would like to talk about a little bit more are the top driver, which is the right care, right time, right place. And the bottom driver that's listed at the bottom is the concept of high-intensity care for our most complex patients. And if you look at the top driver in the very top, there's a term that is increasingly familiar within Kaiser Permanente called senior segmentation, work that we've been involved in for about almost 10 years now, and the terminology for that may start to evolve as we're talking more and more about care groups. But basically the concept is that as people get older, there's one of the primary principles of aging is that there's increasing variation. So that as life's paths progress, people start to vary more and more, and there may be the person in their 60s and 70s who are actually significantly functional impaired or frail, but there may also be the 85-year-old person who's playing tennis and very active. And I think that just Adrian is pointing out the whole concept of having a care map that is based on a disease rather than a larger picture of the context of that disease for different people who are in different statuses really doesn't make sense. So the whole concept of segmentation is really to provide care for disease in the context of the care group which that older person seems to fit best. So one care group would be the robust older adult, who basically really very much is just older, but basically otherwise healthy. And for these patients, we really feel that what is really important to do, and this is where Kaiser is a little bit different from the NHS, is we are in a healthcare system which is a competitive healthcare system. It's very important that Kaiser provide very good care to these members, because basically they are our least costly members, and it's really important that we do not lose these members as a base to offset some of our costs. And what is valuable for a robust set of older adults is basically convenient and reliable care. So basically having ready access to services when they need them, which might not be very often. And we need to create the system that makes this very easy to do, the system that makes it easy to do the right thing. So, no one really wants a colonoscopy, but one thing that would be important is that for the robust older person who needs a colonoscopy, we will make sure that is done promptly and with minimal inconvenience. So Kaiser has done outstanding work with chronic conditions, managing chronic illness, and we actually have done a lot to create the systems where it's easy to do the right thing. So throughout the Kaiser system, every primary care provider will have a panel support tool which will identify which of their members may have any of multiple chronic conditions, atrial fibrillations, anticoagulation, diabetes, and will readily point out the care gaps. You know, who hasn't had a diabetic foot examination, who hasn't had a diabetic eye screen, and those are all set up so that it's very easy to do the wrong thing and the right thing. And then the other thing is the entire team surrounding the primary care physician or provider is enabled to close what we call the care gaps. Now, where we're facing a little bit more of a conundrum are members who have advanced illness, those people with end-stage disease. And I think there's a reason for the conundrum. It's because we have the paradigm of disease care. So if we have one pill for every problem, or as is frequently the case, multiple pills for every problem, and then we have people who seldom have one disease, then we have multi-morbidity, and we actually create the complexity. So then we create the polypharmacy, and then our solution for that is medication reconciliation. And when that is laid on top of a person who has multiple very severe diseases and end-stage diseases, it's not a wonder that our outcomes are not as good in terms of managing these patients, especially when on top of all these factors, there may be superimposed psycho and sociologic issues. And then lastly, we have the care group, which is a little bit of a hybrid group of people with severe frailty and end-of-life concerns. And the reason that these two care groups were put together is basically the principle of what truly makes a difference for this care group, and issues such as the presence or absence of caregivers, because the issues of dependency and needing assistance are much larger. So this is a picture of healthcare in the United States, and actually very much still a picture of care within the Kaiser system, is that there's multiple things available, but who knows who gets what. And this was the problem we were trying to resolve with segmentation. So how do you do this? How do you create the system where it's easy to do the right thing for the right patient? And so we thought about this. And one thing that would make sense is to get patient self-report, because we know with self-report much information is available that basically is best provided by self-report. But we decided against doing that. First of all, we realized that it would be logistically difficult to get self-report from basically 100% of our older adult members. The second thing is, how often do we have to get the self-report? So if we obtain the self-report more frequently, of course it's logistically more complicated. But the other big concern we had with that was that self-report may be inaccurate at any point in time. So let's just say you did a self-report that included questions about geriatric syndromes, functional status, and it was presented every couple years to an 80-year-old person. Well, we know that the life of an 80-year-old person can change at any point in time. And what we wanted was a tool that was accurate for our providers. Because once we get a tool that's not accurate for providers, it's easy for the provider to say, you know, this doesn't make it easy to do the right thing because it's not accurate. The other thing we thought about was actually asking providers themselves to help us with figuring out the care groups. And what we found out was that our primary care providers actually conceptually understood this right away. And they could look at their panel of patients and say, yes, this care group, this care group, this care group. Am I limited in time? Okay, I better speed up quite a bit. We decided against this because of concerns about the amount of work that would be required from the primary care doctors. But what we ended up doing was we ended up developing an algorithm that was based on both the electronic medical record and databases and matched them up. And this slide basically shows the percentage of people that is in each care group, and you can see the relative cost. And then you can tell the absolute cost to the healthcare system based on basically some very simple algebra. And this slide basically shows that there was an internal consistency about the logic model that we use in terms of developing the algorithm, and that most people stayed in the same care group over multiple years. And this slide showed that the people in care group 4, 50% of them passed away over a 2-year period of time, whereas very few people in care group 1 passed away. And this is an interesting slide that just shows the correlation between care groups and the likelihood of rehospitalization. It makes obvious sense that people who are more ill are more likely to be rehospitalized. What isn't so obvious is maybe when you try and do medication reconciliation issues and trying to get them into the clinic, when you realize how frail they are, maybe they're not going to show up just because you set up an appointment, and that's exactly what we found out within the Kaiser system. This is how far along we are on this work, and there remains a lot of variation, and at this point we feel that's appropriate because it's created the interest in moving forward with this work. This slide basically shows that here's a specific usage. The things that we thought were useful to do were done very infrequently. So using the care group model, we can actually say, yes, these are the things that need to be done. So I'm going to move really quickly into the concept of how we go beyond using care groups for specific... Okay. Let me just show you this one slide that, I'm sorry, I do need to stop, was that what we found out is that even within specific segments, what we found out that even though everybody in care group 4 has end-of-life or very frail issues, that still within those care groups, there was a consistent pattern that 20% of those patients cost 80% of the cost. And the exact reasons for this, we're trying to figure out. And here are some of the theories about what may be involved in the determination of what costs money. I, myself, am very interested in the concept of the trustworthy healthcare system. And when you think backwards, how much do your members trust what you're saying in that system? And if they don't trust what you're saying, does it result in higher costs? This is something that we don't know the answer to, and here are some methodologies that we're starting to think about how we're going to approach this question. And we do feel that eventually our most complex, highest cost patients are going to be highest cost, not just because of medical complexity, but because of multiple factors that we really need to figure out. And then our highest intensity intervention will really need to be tailored for those issues. Thank you. Sorry.
Warren, thank you. Warren, thank you very much. I'm really sorry to stop you. That was you're not going to escape that. I thought that was absolutely fascinating. There were so many points that you raised I'd really love to sit and ask you about. Absolutely fascinating. And for us in the UK, the concept of the fit older person and how important it was for your cost base really made me sit up and think. Anyway, what we'll do is we'll take maybe one quick question from the audience, and then we'll get Nancy and Fran to give us a quick distillation of what Twitter is saying. Now, we have a hand up here at the front. I'm going to look towards the back to see if I have a hand up, because it's a bit unfair to bias. Do you know what? You win.
That was absolutely beautiful, sir. Quick question to you, and I think probably you didn't get time. Do you use a predictive tool? I think you touched upon it as a risk stratification model in the community. When you divide the elderly into these 4 segments, do you have a snapshot of the tool that you use, or is there a validated tool that you...
Well, I should say a couple things. The tool that we use, it combines administrative database and combines disease severity diagnoses that we typically use in the United States. Even within the Kaiser system, we found out that different regions have slightly different interpretations of data sets. So it's a little bit of an iterative effort, and basically we're just trying to figure out what seems to make sense, and then we test it against the concepts of what seems to, and it's actually worked out fairly well. One thing that we're very interested in is the one thing that we don't actually have consistently in our records is functional status. But we're starting to get a fairly large cohort in which we can check functional status and see whether that adds more to our algorithm.
Warren, thank you very much. Come on down here a wee sec, because we're going to have a chat. Right, come and let's hear what our Twitter followers are saying. Do you want to go there, Nancy? Fire away. Tell us what folk are saying. Just before you go, let me share with the audience. You may have seen Dave come and whisper something in my ear. You've all chaired meetings, haven't you? You've all been speakers. Dave come up and he whispered, he said, there may be a short delay, I have to find the next presentation. So if that puts the heart across you as a speaker or a chair. Okay, fire away there, Nancy.
So, the question, most elderly specialists agree that more care should be in the community. How can we provide meaningful data to show that it works?
Yeah, I think it's, at this point, a theory that really needs to be tested. I know that the statistics in the UK are about 60 or 70% of hospital care is for older adults. In the United States, it's much less, but we do know that in the hospital, about 2% of our members, less than 2% of our members are age 85 and older, and account for about 10% of our hospital beds. And when you look at the outcomes of hospital stays, for just simply by age, the outcomes are quite dismal. So it gets down to the issue of you know, what is good care, what is optimal care, in which setting, and the question about whether care based in the community will be have a more positive effect on the overall cost of healthcare is still with a theory that we're even wondering about within the Kaiser system, but we think we need to go in that direction.
Any more there, Nancy? Fran, you have a question, I think?
Sorry. There's a question from somebody asking about why there's not a segmented care group for people with learning disabilities. Obviously it's not a disease, but it does impact hugely on healthcare, and she was wondering where that falls in the bucket.
Yeah, so I think the whole concept of where we are is that there's a lot of variation in the concepts about care grouping right now, and I've come to really realize that that's positive as we start to understand things better and as things are developed. So actually, one of the Kaiser regions not only did it on older adults, they did it on the entire population, which it's fascinating to see the different ways that this can be done. Of course, being a geriatrician, my focus was really on older adults with the typical problems.
Warren, thank you very much. Absolutely wonderful. Thank you very much indeed.